Hi, everyone. Welcome to today's roundtable. Today we have Dr. John Haughton with us. We also have our amazing Renegade Research team or part of the team with us today. A few reminders that we have a research roundtable next Thursday, and that's going to be at 1 p.m. Eastern as well. And then we have the series with Dr. Afrin during the month of June, and we'll be posting the links to that in a little bit. And we want to thank Dr. Haughton for being here today. He was one of the first people to join us when Remission Biome got started. He's been an amazing supporter, an amazing person to consult with, and we are really, really thankful for his expertise and support. Dr. Haughton has over 30 years of experience in patient care workflow technology, healthcare research, and clinical informatics. He's a physician trained in geriatric rehabilitation and a background in electrical engineering with experience as a clinician and senior executive in quality and clinical information management. John focuses on activities on applications involving care management across the continuum, evidence-based clinical measures, population analytics, and pay for performance. He approaches clinical care from a systems perspective, informed from his experience with bone cancer as a teenager and radiation fibrosis inflammation effects from 2010 to 2020, overlapping with long COVID from 2020 to 2022. Since that time, he has enjoyed improved health and vitality using a combination of approaches addressing the triggers and resolution of an overabundant inflammatory process. He shares the approach with others and looks forward to the time when we are treating millions of people with long COVID and ME/CFS at scale with coordinated science-driven interventions. His current work focuses on effective clinical care approaches that quiet inflammation and fibrotic processes using existing, inexpensive, accessible actions and activities that track the science and biochemical pathways, including TLR4, RAGE, M1 and 2 monocytes and macrophage balance, glycolysis, DCI balance, microclots, blood flow, hypoxia, etc. He's a big fan of metformin and berberine, curcuminoids, nanokinase, and smooth muscle relaxants, along with probiotics for the gut. Dr. Haughton is an authority on risk adjustment methodologies, predictive modeling, disease and care management, evidence-based measures of development, physician profiling, and healthcare and clinical information systems for the payer, provider, patient, and community. He has worked across the spectrum of healthcare with the Institute for Healthcare Improvement, federal and state governments, private industry, major health plans, provider networks, and individual physicians in designing effective care management and risk identification programs and software tools. John successfully drives changes as a health plan quality officer, CMO, for plans from 5-star to 2.5 stars. He also founded DocuSite, was an SVP for product and research at DXCG, SVP of Clinical Integration and Product Development at Active Health, and CEO of CogniMed. Clinically, he has served as VP of Medical Affairs and ran an independent outpatient geriatric rehab practice in Massachusetts. And he completed his rehab residency at the University of Washington, where he was the chief resident. Thank you so much for being with us today, Dr. Haughton, and the floor is yours.
Thanks. Really looking forward to the conversation. I've got some slides and to go over some of the background, but what I'm really excited about is the conversation we can all have and questions. And thanks, some people sent some in over the last week around whether inflammation can cause depression and anxiety, and what are some of the, how does solidexide work, and a few other questions. So I'm going to share my slides and hopefully we'll be off to the races. Can I just get a confirmation that the slides are on as I think they are?
Yes, you can see them.
Great, thank you. So overall, and thanks for the comments, Isabel. And I first want to just reach to the whole remission biome process. And activities. It's incredible the work that's been done from grassroots to getting support to measurement to expanding new protocols and groups beyond the remission biome. But the general concept of it's not okay to be satisfied with just living with an ongoing chronic disease if there's something that can be done about it. And like we all realize, there aren't always magic wands, and it's not everybody doesn't reverse everything all the way. But boy, are we learning a lot more about how to get this under control. And the path that I've come on is really a combination of personal and professional of kind of what works. And had some good luck with my own inflammatory processes and reversing them. Some family members, and then out beyond that. And many of the things are very simple, and it takes 6 to 12 weeks to see if there's an effect or not. And I'm just looking forward to talking about that. There we go. So from a clinical perspective, the approach, it's like a lot of clinical activities, but the approach, does the person have it? And so are there labs around that suggest inflammation? Maybe there's an imbalance in some of the lymphocytes. Symptoms certainly are key, whether it's fatigue or GI or POTS, heart rate issues, fatigue in terms of endurance issues. They absolutely really listening to people. One of the folks I worked with clinically last year, who's had a great response, was just spending some time talking, and she had really bad migraines and fatigue, and was sort of I think she was about 0.4, and she ended up was working full time, but it really couldn't put her cognitive all into it because of exhaustion, and certainly did not have the endurance to do what she was used to with her friends out in the community. And after just talking for a while, she was initially talking about fatigue and migraine, and zeroed in on the fact that she'd always been able to write, if she scratched her arm, she would get red flares on it, which is a super marker for MCAS and some of the inflammation. And she had great response with putting some antihistamines in place, which people hadn't done, along with some of what we'll talk about with the humanoids, and then she ended up doing some hyperbaric oxygen as well, but has had a wonderful response. And I think in the Twitter sphere, we see I think that there are a lot of people with more severe disease, and people talk about 20 million people in the U.S., probably and multiples of that across the world with long COVID, but the number that haven't declared as having long COVID, but are still affected by the inflammatory processes. It's a huge issue, and the overlap with potential dementia, with the other inflammatory conditions is very real. And some of somebody who's got cardiac issues that are small vessel disease based may be treated as cardiac issues when the root cause is really this ongoing chronic inflammation. The toolkit and the approach, so it's hard to get people that are versed and comfortable in what's going on across all the domains. I mean, personally, in medical school, I didn't pay that much attention to the Krebs cycle and all the biochemical pathways. And as when I first started doing clinical work, the taking care of people with chronic fatigue syndrome really didn't have that much to offer them. I would give them some tricyclic antidepressants and gabapentin was pretty new then, and maybe try that and a few other things, and some pacing equivalents, but it was really getting at the underlying issues of what's going on. It wasn't known, so it wasn't particularly satisfying. And it's over the last few years, kind of diving into this more deeply to understand it. The body's got one of the most elegant control systems. It beats anything we design in the electrical engineering side. And it's basically a balance between the inflammation and the killer side of the white blood cells, the M1 phenotypes, and the M2, the build side. And an easy way to visualize it is what happens with wound healing. With wound healing, if you scrape your knee, the first thing that happens is it bleeds, and then the crud gets pulled out, and that crud is the inflammatory white blood cells, and they are you hear words like monocytes and macrophages and different types of cells, but the macrophages are sort of like the Pac-Man. They gobble stuff up, and then when that gets engulfed, those the materials and proteins get recycled. So that ends up being an important part. A wound won't heal if you don't have that inflammatory part at the beginning. But if you don't have enough oxygen getting to the tissues in a wound, and it becomes a chronic wound and a chronic disease, you don't end up with healing. You just end up with an open, festering, kind of liquid releasing wound, and it doesn't always cause more problems and spread. Sometimes it'll get infected, but it just has an ongoing inflammatory process and won't heal until you flip to the M2 phenotypes and bring in the white cells that are then laying down matrix and building new material, and ultimately closing off the wounds, and then new blood vessels come in, and so on. And that process really seems to be very out of whack in ME/CFS and with long COVID, and that's really at the core of what we're talking about here. Question, kind of how did I get here? I'm a big Talking Heads fan, so if all goes well, I'm gonna turn on a Talking Heads song here, maybe. If it doesn't, I'll just talk about it. Why isn't it? I don't know why. There we go. So I'm a big David Byrne fan. The lyrics of the Once in a Lifetime are about how do we get here, the meaning of life, all these different pieces. I'll stop it because it's probably a little distracting now, but there we go. But for me, there's an arc in life around it. Talking Heads was the first concert I saw as a kid, and it was back in the 70s, and it was just the four of them, Talking Heads, before they ended up getting a whole big brass section and stuff. But it just always resonated with me, some of those songs. And the answer as it relates to this talk and the deep dive into long COVID comes from a history of having a bone cancer as a kid, followed up with some later on complications that were related to chronic inflammation and dovetailing with a bit of long COVID. And what it is, so this is a picture of the NIH Clinical Center. I took it when I went to they had an ME/CFS conference in December of this year, and that felt like old home week to me. Back in 1981, I was in this building when it used to be the hospital, and got my cancer treatment there. And somebody at the time had written a little book about teenage hospital experience. You can handle it, and interviewed a bunch of people. So that's a picture way back when. And then this was 40 years later. A few years ago, I tweeted out, just excited to still have my leg and it all worked. You end up with complications with fibrosis and inflammation that can happen over time. My leg worked pretty well throughout life, and then got a wound that didn't heal in 2014, and ultimately it ended up with a giant flap, this kind of round piece here that came from my thigh. The people at Georgetown are magicians. My favorite, Dr. Karen Evans was absolutely incredible at limb salvage. And it all works great. And then had a tiny bit of a complication in 2019 around this. I'm not sure if people can see, but the hospital plate of carrots is not a very appetizing food. And so maybe that was one of the biggest risks going into the hospital sometimes. But then everything healed, and in 2021, I was trying to figure out, kind of through the fall, was there anything I could do to keep the leg from breaking down again, the fibrosis from breaking down? And all my life, I had a endurance not fully there. So if I went to play basketball, I completely got winded just running up and down the court once, but walking around and day-to-day activities, no problem. And ended up stumbling on Metformin in December, and then went to my annual physical with my own doctor in January, and asked if, talk to him about taking Metformin as a potential way to heal, to keep the leg from breaking down again. And the doctor had always been taught of Metformin as a diabetic drug, and what it really is an anti-inflammatory drug that happens to have anti-diabetic properties because it sensitizes insulin and makes the cells work a little bit, where metabolism works better. But the reason for bringing it up here is that then in March of 2022, so 6 or 8 weeks into it, all of a sudden I noticed that my head was a lot clearer. And that I could multitask like I hadn't been able to do for a while, and realized in that process there was, so back when I had the cancer, there's a concept people have after the chemo to call chemo brain, and it's sort of the same thing of kind of thinking isn't quite as fast, and short-term memory can have challenges and things. And honestly, I just thought in the 2020s I was just getting old. And in 6 or 8 weeks into starting Metformin, it really changed. And I had not been very active on Twitter or anything like that. But when I wanted to see are other people with, and I had COVID in 2020, and realized that there may be a connection because people were starting to talk about brain fog and long COVID at that time in the spring of 2022. And came across a woman over in Israel who had taken Metformin for
John,
yeah.
sorry to interrupt. We're having a little bit of a trouble with the audio. When you turn to your left and get a little bit closer, it sounds a lot better.
Okay. I will. Thank you very much.
Okay. Yeah, that's great.
Okay. Anyway, and she had been taking it and found that it ended up helping. Like ultimately, it wasn't the perfect answer, but it helped. And the sort of mental model that started coming into focus was this brain fog is somehow related to inflammation. Metformin's related to it. And then dove down from there, and lots of the people in the panel here and others out in the Twitter sphere that are brilliant in terms of the biochemical pathways and everything else talk about it. This is the way I keep track of it myself. This is my world on my phone. I just when I find something that's interesting, I make a note on it and go from there. And over the last couple of years, there are about 3,900 entries, and some are useful and some are useless. But last week, this is what it was. They said they're interested in boron may have some lowering help with HIF1 and inflammation. And I don't know very much about it, but I'm very interested to see if that might be a good opportunity. The treatment, the RAGE pathway is important, and calprotectin, which is also S100 A8, A9 is a key constituent of it from a pathway, and anyway, but that's it. And so it's a very organic pathway, And I just wanted to take a moment to sort of describe where it came from. And I think we all have our stories, and they make real good sense. And maybe at the at the end of life, maybe there is a reason why we all got here. I want to shout out to the Unite the Fight conference over the last couple of days. It was it's so impactful seeing the brilliance and the endurance and the effort of patients and basic scientists and clinicians all together working through, and the 5 or 6 folks who were the core team of putting it on. It's just unbelievable to think that in 2 months, going from scratch, you could end up with 10,000 people signed up for a conference, and routinely having thousands in lecture halls. It's remarkable, but it says there's a real issue and a real problem here going forward that we want to work on. I pulled these a couple screenshots. Dr. Asaki talks about potential root causes in the article that he and some others did in the last a year ago. But you've got virus, you've got autoimmunity, so the flare up of all this inflammation, and you've got tissue damage and dysfunction in the endothelium, in the interstitial space, with clotting cascades and so on. Is there latent virus, whether that's virus or virus parts? Is it in everybody or in some? I think all these together really play the picture, and we're just going to dive into a little bit more of a conversation about that. And when people make measurements, you see that it's a combination in general of inflammatory issues, and then there's some changes in some of the hormones, and whether those are because you end up with fibrosis in some of the organs that are generating the hormones, or whether it's a central downplay and quieting of the ability to generate the signals in the first place is still getting unraveled. The clinician biome certainly has a whole idea of the brain stem and sickness behaviors, and the vagal nerve connections has been front and center. And then the communication down to the gut with the old brain into the vagus nerve is key. So it comes down to, or the way to think about it anyway, is the TLR4, the receptor, is a key part of this. And we have a series of receptors, those danger-associated receptors, they're called TLR. They go from about 1 to 10, or maybe even more. But TLR4 has historically been related to sepsis, and it's particularly sensitive to the outer coating of some of the gram-negative bacteria. The lipopolysaccharide coating fits really nicely into the TLR4 receptor. And when the TLR4 receptor gets that key into the TLR4 lock, it turns on the body and pushes it towards this inflammatory state. And that includes the M1 macrophages and the killers, and those are useful if you need new blood vessels. Inflammation allows tunneling into tissues to create new blood vessels, but it causes all sorts of havoc if you've got chronic ongoing inflammation and cytokine production when you don't want it. And going back to the wound healing, that's that chronic inflamed non-healing wound state, and it may well be that the body at large, because of the distribution of the small vessel endothelium, is just attacked in a kind of a non-healing inflammatory state. And sometimes it'll pick up in the muscles more, sometimes in the brain, sometimes with cardiac small vessel disease. And if there's no reason to think that it isn't a combination of responses, it actually ends up being kind of Very simple. It's like the little kid's teeter-totter. Is the teeter-totter flipped or the balance flipped towards M1 or towards M2? And when it's in balance, your body can break stuff down and it can build stuff up and create new things. But when it's out of balance, whether it's just straight autoimmune disease like lupus or rheumatoid arthritis or MS or others, and some of those are certainly likely post-viral as well, with MS and Epstein-Barr. But when that balance is tipped, it's just like my voice was when I was turning my head to the right. It gets muddy. So some of the stuff is still there, but it doesn't have the fidelity that's really needed and going forward to keep the body in balance. And so then the body just gets into this fibrotic state. When the toll-like-4 receptor gets turned on and the innate immunity gets picked up, that process of balance ends up the pivot point of the teeter-totter, or maybe it's the things on both ends, are something called HIF1, which is it gets driven into the nucleus, and when it does, it starts creating, it has the genetic instructions that starts having the nucleus of the cell spit out proteins that are the cytokines, these things like the IL, this and that. The 6 is certainly a large offender. And it is, interestingly, it's lowered with increasing oxygen flow, and the reverse is it is high when oxygen is down. So that is for me anyway, was the missing link as to how could you have somebody have a vaccine and then all of a sudden get into this hyper or ongoing inflammatory state? Or how could you have the virus infection occur or viral infection and still get into an inflammatory state? And there certainly are examples going out to well more than a year or two where ongoing viral particles or breakdown products or RNA or messages are there. So there's evidence of the virus, and it's not weird to think that there might be places where replication is occurring, but it doesn't seem like it's all over everywhere for everyone. So how could you end up having an ongoing inflammatory process without the driver? And so somehow there has to be a loop that says, once you start the process can keep going on its own. And this HIF1, for me anyway, from the systems perspective, is a key way to think about that loop. So if you have a small vessel that ends up getting clogged up because the white cells have gotten inflamed and they spit out their nets, and the nets end up capturing some platelets and ultimately create a microclot, then that's going to plug up the blood flow through that small vessel. And so, and these things are, the fractions of a hair wide, some of them, just enough for a cell, one cell to get through, or a red blood cell to get through at a time, and deposit its oxygen, and then the pull back waste products and go from the blood vessels to the nearby lymph system, the garbage collecting system, through the regular tissue. And within that tissue, you have things called tissue resident macrophages. And so they can get flared up, and that's where some of the MTAS comes from. But this HIF1, because it gets implemented and pushed into the nucleus when there is low oxygen flow, the very fact of having inflammation or clot lowers oxygen, lowers blood flow, then that creates more HIF1 in the nucleus, which creates more inflammation, the cytokines, which flare up and constrict those micro blood vessels. And that's enough to just keep this thing going. And then within within the mitochondria, and there are others on this call who are far more expert than I am on this, but within the mitochondria, you end up with a metabolic balance also between the TCA cycle or the Krebs cycle or the regular oxidative phosphorylation, where the unit of glucose or sugar, the raw material, ends up making 30 plus ATP. So a lot of the energy units, the ATP, or you can get into glycolysis, where you're only getting a few ATP for each cycle. And when you have people talking about the taconate shunt and those things, a lot of these are the balance between the oxidative phosphorylation and the glycolysis. Essentially, parts of it are similar to fermentation anyway. But you just don't end up with as much energy. It turns out that metformin ends up helping to balance against the HIF1 and push the other part of the teeter-totter is the NRF2. And it's not the only thing, and we'll dive a little bit more deeply into that. So that counterbalance is the M2 build, the NRF2, when it goes into the cell, into the nucleus, it then spits out some of the constituents that push the building part. And remember, going back to that wound, initially you want to break down the killer part to pull the crud away, but then you want the builder part to lay the planks and build out the tissue. And the NRF2 and the M2 builder do that. Personally, I think when people talk about a remission event in the remission biome and these sort of flips that occur that really happen on in an order of sometimes minutes to hours, or certainly within a day or so, it's a very fast process that it may well be flipping that teeter-totter back into balance. And overall, it quiets down something called inflammasomes. NLRP3 is one of those, and that's one of those pieces that flares up and also makes the cytokines go out. And the details of what are all these things called don't really matter. It's important to make sure everybody's communicating. But broadly, if you step back and say, what is this? It's a spike that turns out 3 spikes together fit almost perfectly in that TLR4 receptor. So it's like a skeleton key or a fake key that can go in there, but once it's in there, it can lock and turn on the innate immune system more than you'd want it to. And that can happen in white blood cells, so it can push them from a balance into more of that inflammatory state, and that's the NETs, and then that ultimately results in the microclots. But it also is on the wall of the blood vessels, the endothelium that can happen, and you get inflammation there. And then what happens is it makes the cells of the blood vessel get inflamed, and they can spread apart some. So you get some movement of fluids back and forth into the interstitial tissue. And then that's where you start flaring up the histamines and the mast cells and the MCAS. And then when that happens, that starts pushing the intrinsic clotting cascade. And when that happens, the platelets clump. And when the platelets clump, and then especially if the little nets are there, that's where you get the blockage again. So all these things kind of work hand in hand to start the process and tear it down. And then the trick clinically is trying to stop it. So I don't know if others do or not, but I stumbled a pile on what the heck were all these different phages and poses. And so I made a little bit of a list of them here, and for the pure biochemical folks, chemistry folks, I probably have butchered them. But broadly, the poses end up in death of that whole entity. So mitopsis might be the mitochondria going away. Ferropsis is iron-driven cell death. Apoptosis is the whole cell death in general. And then the phages tend to be recycling parts of the cells. And so the body doesn't, it actually has a pretty good recycling system, whether it's the whole cells or whether it's the whole cells or part of them. If it's part of them, it can recycle right back into the cell, some of the autonomous cell processes. And if it's the whole cell, it recycles, and those materials get taken back through the lymph system and then move back throughout the body in their raw materials. And then there's sometimes you can end up with extracellular things. So if you have the cell wall and then the nucleus is inside the cell and the mitochondria is usually inside the cell, you can also end up with things that are kind of floating in the blood, thinking of those spaceships running around, and the exosomes, and so they're outside of the blood cell. And they can carry loads. They can carry caustic payloads. They can be inflammatory. And there's a concept that's emerging, coming out more. It's probably old for some, but it's new for me. Of cell-free mitochondria, where that may be one of the missing pieces as to why is somebody's pulse ox really good, but they have no energy. And then if you do a venous blood on them, you find out that the oxygen in the venous blood is below the basement level. It's super low, which says a bunch of extraction has occurred. And how could that happen? And if there are cell-free mitochondria running around, and if you have these micro vessels, small vessels blocked, then those mitochondria can be hanging out there, just eating up all that oxygen that's left, but not doing it because there's limited oxygen, and that HIF is still picking out the cytokines. It has the teeter-totter tipped into the inflammatory state, which is an inefficient metabolism state, and so it's creating just a few of the ATP at a time instead of lots of it. And as a result, it just simply isn't enough, and the body needs to use those few ATP to just keep its core processes going. So there isn't enough energy to get out of bed and walk around. Or if you're used to running marathons and now can just walk in and out of the house, you may be doing pretty well from the outside, but it's not the way it used to be. And speed of processing in the brain takes a lot of energy as well. So I think we'll hear more about those, and I'd love in this discussion, when we're done with the formal part of the remarks, to get into some of that cell-free mitochondria. I think it's a really important concept here. And this is a picture, I think, of every one of these talks. At some point, you got to get to the pictures of what are the cell processes and what do they look like. But hopefully, this is useful with the discussion we've had. That you've got outside the cell things, and that's where some of the toll-like receptors are outside the cell, and some are inside the cell. TLR3 certainly has something to do with the long COVID activities, but it's inside the cell. The outside one is TLR4. Interestingly, something I came across the other day was TLR2 is the one that's implicated with Lyme disease, and so there could be different triggering mechanisms that then can end up with common pathways of this teeter-totter. Are we in the inflame area, or are we in the build area? And then I saw for a while on Twitter that people were talking about S100 A8 and 9, and whenever I read it, it seemed like it was important, but I really didn't know what it was. And then people talk about inflammatory bowel disease and Crohn's, calprotectin, and that seemed to be an important thing to measure for inflammation. And then lo and behold, they're the same thing. And they are the agonists, or the things that fire off the rage pathway. And this is a place where when that pathway is fired up, and the NYD88 is part of that, that's the place where heparin is good at breaking the rage feedback loop. And so some people have really good responses to low molecular weight heparin. That may be because it's helping to grease the skids and open up the blood vessels from an anticoagulant perspective, or from a keeping things apart perspective. But there's another part where it's just very specifically is a blocker of the RAGE pathway. So solidexide is really like low molecular weight heparin, but it has a piece on it so it can be taken orally. And that's not a drug that's available in the US. It's available elsewhere in the world. And it has some potential for good activities, and love to hear about that too, if people had good response with it or not, or complications. But the idea of an oral agent that could be taken and then broken into heparin, and then the other part that makes it orally absorbed, it breaks away, is attractive, because low molecular weight heparin, you give yourself a little shot under the skin. It's nothing worth in the world, but it's potentially an issue. And then so you have TLR4 to trigger these processes, and that fires up the RAGE pathways. And then that starts to do this whole thing with the chronic inflammation, and pops the HIF into to start helping the nucleus to spit out a bunch of the inflammatory cytokines, and that's the chronic inflammation. So this is the sort of chunking it down into what could work, and the idea behind it is, here you go to try to get into a long COVID clinic, you find a lot of them are closing down. You find a lot of them, you go in, you get an intake, and you might have waited for 2 or 3 months to get there. You certainly have somebody in the clinic as compassionate, usually pretty smart across a bunch of the different body pathways, but very often it'll be, I'm having trouble breathing, so now I go to the pulmonologist, and my heart hurts once in a while, or I've got my heart rate's too much, or I miss a beat, so then you go to the cardiologist. And after I eat the wrong way and my stomach's irritated, then you go to the GI doctor. And so all of a sudden you go in, you get a spread of specialty consults, and then you come back together afterwards to hopefully put it all together. And what are you going to do, and what's going on? You can treat on each of those organ systems, but there may be value in trying to treat that underlying issue that may be driving the inflammation in each organ system. That then, if you can get the underlying inflammation to go and get the blood flowing, you get the balance between HIF1 and NRF2 and the M1, M2 macrophages and monocytes back at the right level, then some of the problems may go away over time. And so the 4 steps are really to say, tackle the virus. And if you're within 6 months of your of the COVID infection, and there's reason to think there's ongoing viral load, absolutely go after some of the antivirals. Many of them can also have side effects on their own, so it's important to monitor kidney and other parts of the conditions. And many of them you need to get prescriptions for. What I try to do in this process is to say, is there a way, if it's really going to be at scale, it's got to be something that somebody can access directly, can't be too expensive, and could work in a coordinated way with the formal healthcare system. And certainly it's useful to get labs and other things. But so then, are there antivirals that are non-prescription? And so the Metformin works great, but then there's something that's sort of a similar mechanisms. It's a little bit different, called berberin, and that might be perfectly good piece instead of having the prescription drug to use that as a supplement. There are some metformin for sure has some antiviral properties, and there are other things that do too. So looking on the supplements is a way to think about it. But work on the virus and spike protein. Very intrigued about, and I don't have personal experience with it, but the whole nicotine pathway of using the nicotine to be a competitive inhibitor to free the spike and get it out so it can then start to get digested is a really interesting concept that I think should be kept front and center. Then the dropping the cytokine storm, make sure that the antihistamines are there and the MCAS, the platelet activation, aspirin, or and you can take some other things that require prescriptions. But the idea to try and quiet down the inflammation, and then that would also work with things like just to quiet down the TLR4. And people have had good response with low-dose naltrexone that drops TLR4. We're waiting on a study to come out of Buffalo on low-dose lithium, which also does 10 milligrams of lithium. I think they're studying lithium oxalate, which is the supplement we can get, versus the lithium for mental health reasons, is more like 300 milligrams. And but low-dose lithium has TLR4 activities. And then it turns out that curcumin does, or turmeric. And there are studies that show, if you dive into the back pain literature, that higher doses of curcumin for 4 to 7 days, you can see some effect on back pain with it. And so that may well be the same kind of inflammatory pathways. But that ends up being a good one. Sometimes people get constipated with it, but in general, it's fairly benign. And then once you've got all of this quieting inflammation, you've got to get the blood flowing again. And so then the breaking apart the microclots, there was a survey that was done a few years back by Organic Music, the PharmD, and she found that the action or the intervention that helped the most with or among the most with long COVID symptoms were the nattokinase serapase items. And those are the breakdown proteins, so they can work to break down the microclots. I'm interested in trying to dive into more detail on boron. Would that end up having the same sort of effect of anti-inflammatory and breaking down some protein breakdown? And we'd love to hear also on that. But really deliberately try to go after something that is breaking up the nets and the clumps to get the blood flowing in the small vessels. And to again get the blood flowing, you get oxygen, and that drives NRF2 instead of HIF1. And so that should break the cycle. And then on the mitochondrial energy side and the tissue gut balance, certainly seems very useful to try to push short chain fatty acid increases in the gut. And in fact, that may be one of the big things that metformin and berberine do. They tend to increase the short chain fatty acid, raw material in the gut. And on the mitochondrial energy side, taurine is really interesting. And as people age, their taurine levels go down. Personally, I was all excited and this winter tried some taurine, and for me, it didn't make a difference, but I might not have a deficit of it. But others have had really good effect with it. And it's fascinating because inside the mitochondria, there's a whole bunch of oxygen reactions. And when you get these reactive oxygen species, where basically an oxygen is stable and happy when it has 2 electrons on it, but if one of those gets ripped off, it's really hungry to get another one, and that ends up being the reactive oxygen species, and so that people talk about are OS. And the taurine is very helpful with something in the mitochondria that's related to sopping up reactive oxygen species. And then the last piece of it is and it opens up a whole new front of attack, is the idea of senescent cells. So the body's pretty smart in terms of what if a cell gets goofed up and doesn't have all the things in it it ought to, and but still can do a little bit of stuff, then it can, but you don't want it to replicate because then maybe it'll turn into cancer. And it turns out the body figured out a way to do that, of saying, take a cell, put it into the old folks home, and it's a senescent cell, and it hangs out. It can hang out for ages without breaking down, and it unfortunately it also spits out some inflammatory cytokines usually, but it doesn't replicate. And so it may be that after the acute phase is over, you've got these things hanging out for a long time, causing issues. And so there are some there's some pretty heavy duty senolytics, and then there are also some what looks to be pretty benign ones. Nicotine is a fascinating one. It's super active. It comes from strawberries. People are still messing around with what is the dose like on it, but it has capabilities to break down some of these senolytics or senescent cells. And so that could be an action. I'm going back to the personal level. Throughout from the time I was 18 till I was 58, I had a pulse ox that was typically around 92% or so. And when I started the process of taking the metformin, after somewhere around 6 months to a year, I was doing a pulse ox and realized it was higher. And at this point now, 2 years later, it tends to be 96 to 100. And I haven't had that since I was 18. I don't think that's everybody, but it says to me that the fibrosis is reversible. And in that leg that I had all the radiation on, the back of the leg used to feel almost like wood. It was just all scar tissue, and now it's just over time it's more supple than it has been. And so I'm cautiously optimistic that a bunch of this stuff really is reversible. And there's in fibrosis in the lungs. There's a medicine called bleomycin, which is I think it's a chemotherapy medicine, but it causes inflammation in the lungs and causes fibrosis. And metformin is one of the drugs that has been shown to help with bleomycin derived fibrosis. So all these pathways that we're talking about here I don't think any of them are perfect, but collectively they work hand in hand. And the idea is get the blood flowing, tilt the teeter-totter in the right way, and back into balance, and try to get rid of the inflammatory constituents, and then potentially add things that will get from a senescence perspective, get rid of the senescent cells. And this is really just a repeat of that as words. So if you walk down these bullet points, it's kind of the path. So the spike is getting the infection, the inflammation, and when the white cells are there, flipping to this M1 phenotype. When you get inflammation in those small vessels, you're getting some flare up in the interstitial tissues, the tissue resident macrophages, and the mast cells are going to also start pushing out their histamine, which makes stuff leak here. There are definitely the nets and Danielle, I think is the first name, but Beckman. There's just some amazing pictures of what do nets look like, and what happens. What does inflammation look like in with white cells and some of the nerves that are infected? You can kind of see the whole inflammation at a level of a nerve, and then all of that drives hypoxia. And that hypoxia drives the HIF1, which drives more inflammation. And because somebody asked about those senolytics, that just is in the rage pathway, is one of the things that can quiet that down, that's inside the cell more. And then on the TLR4, the curcumin is absolutely works there. The metformin has the effect, and may also have the effect of short chain fatty acids. in the gut, and so balanced. Low dose naltrexone is great on TLR4, low dose lithium, and then I think boron is, I just don't have enough experience, and the literature is harder to come by, but keep an eye on it, I think. And then Vicodin, and then there's something Nicotine, and there's a D and Q is this senescence, but I just sort of fell over this putting effort towards Vicodin because it just seems like it's easy to get, cheap, and it's safe. So stop the virus, limit the inflammation, prevent the microclots, treat the microclots, and restore oxygen. And that's what it's about. And in the process, you'll end up, you can be able to break down some of the fibrin and fibrosis, get the flow going that way, hopefully get the endothelium working better, and get rid of some of the zombie cells and let them recycle. And fingers crossed, and hope is not a strategy, but that you get the flip back, so then you see some of these remission events where you get more towards the oxidative phosphorylation and get really enough energy, so you're not just living right at the end edge of your energy envelope all the time. And try to come up with some sort of a clever acronym, and really always that just goes through it with vigor to potentially do it. And there's just different ways to describe. These are pictures that have developed, and they're trying to understand it more over time.
John, the sound is muffled again.
Oh, sorry about. Thank you.
Yeah.
I was looking at the slides. All right. And so I think I'll stop here. And we're sitting about the top of the hour, and let's open it up for discussion. Let me just double check if there's anything critical on the other slide. And I think this is a good start. Oh, here, this is probably useful. The goal of how do you do this at scale is something that somebody could do on their own. $100 a month is still expensive, but it can't be. I cringe at the studies going first after does this antibody that's super expensive solve the problem, without asking does this metformin or something solve the problem as well. And it's always good to, antibodies are nice because they fit a particular receptor, but there's a really cool study that's was talked about on Unite the Fight that Dr. Eli's doing, and they're going to bring in Dr. Bernante from Minneapolis, which is very cool, for a second phase of it, to look at metformin as well, but to see if those will end up helping to quiet things down in long COVID. And so if I had a magic wand, I would have done it the other way, or I would have had an active, if anybody knows how to get in there to get them to do an active placebo arm of metformin, comparing it versus just raw placebo, that would be useful, because what I'm worried is, it'll take a year or two to get the study out. The study will say this antibody works great, and it probably will, but it's super expensive, so it's hard to get at it. When a less than $20 a month, really less than $10 a month drug could work, and if somebody would do an active control with berberine as well, you might find that it doesn't need prescriptions to make it go. So that's my editorial, and I'll stop there. But why don't we turn the slides off and go to the questions? And turn the slides off, and you help go into the questions. Maybe others have been looking at them. And
okay. Well, we do have a couple of questions that came in the Q&A, and then there's a couple of the panelists that might have a few questions. So we'll start off with the ones that are in the Q&A, and I'll ask you those because the two that are here are ones that can't be brought up. I mean, they can't get a chance to speak themselves.
sure.
But the question was, were you saying that fluorine affects ROS, or was that something else?
It wasn't fluorine.
Taurine.
Oh,
Was it
taurine.
taurine?
Oh, yeah.
Okay.
Taurine. Thank you. Yeah, so taurine is a supplement, and it works part of how it works is on superoxygen dismutase. And I think Nick is on here. He knows this stuff backwards, forwards, inside out. And may have some comments on it. But it is the taurine levels go down with age. And so, and it may, in fact, be that they go down with inflammation. But it's something that is probably not trying it and finding it doesn't work. It's not going to have a lot of issues, and that's what it was about. The taurine is talking about. I think the one that we've seen consistently working from people trying to reverse some of their symptoms is that one of the best is the curcumin and two of the best. I wouldn't curcumin and metformin.
Couldn't hear that last part.
The curcumin and the metformin, and with curcumin, you want to get up to about 500 milligrams of curcuminoids, which is, you have to look very closely on the labels to find out what's there. A lot of them are 50 or 100 milligrams, and the labels are written in such a way you think you're getting a lot more. But you can find them that have the you can get 400 or 500 milligrams in one pill sometimes, and then some of those also have fillers, and so then you got to figure out, are you allergic to fillers or not? Those are the issues. But that's a really good way to go.
And then the next question would love to hear more about the effect of heparin or yeah. I'm not even saying it right. Heparin, and how you might expect to prescribe it, and how do you see the change in the patients, and then how long should they keep taking it?
Yeah, so the heparin and solid oxide would fall into the same camp. I think the heparin use has typically been low molecular weight heparin, and that ends up being a subcutaneous little shot under your skin. And there's a standard dosing protocol for it. You are going to need a prescription for that, and you can do that with your doctor. And it's the same type of dosing and treatment that sometimes after orthopedic surgery for a knee replacement or something, people will give the patient low molecular weight heparin when they go home. And it's the same thing. And so, trying that for a month or two with the standard dosing would be, if you're not seeing an effect within 4 to 8 weeks, maybe something had to happen before to make the effect go, or not. And I think in general, if the body's healing right, it tends to be a 4 to 8 to 12 week process. And think of that skin knee, think of a broken leg, all those sorts of things. And so if you're not seeing an effect, it doesn't necessarily mean that thing doesn't work, but there may be something you have to do beforehand to make it go. But that would be a pretty straightforward way to try it.
And the next question comes from one of our panelists. If you're ready to ask a question.
Yes. So you were talking about metformin and the effects on M1. What happens if you have somebody who is on the M2 side of that teeter-totter? And is that something where we could actually predict the potential response to metformin? Yeah,
so it's interesting. There are definitely people that have paradoxical effects to metformin is one thing, which is not directly answering the question. It goes back to that teeter-totter. But there are, and the conversations I've had with folks around it have been, it tends to be, so far anyway, people who have more severe disease for a longer period of time. And I really wonder if it made me, when I first in 2022 was so excited about it, and then basically got slapped in the face in a very congenial way about having being an idiot for just having uninterrupted excitement about metformin, that it can cause some issues. And we got into some very thoughtful discussions with one of the folks who's on Twitter a lot, and I don't know whether she's about me to say her name or not, so I won't, but super great person. But anyway, And it got me thinking of, why would that be? I think the mental model, and I don't know if it's right, but is that somebody earlier in their disease has more reserve or less cells have been affected. And so, during the Unite the Fight talks, there were some talks about the idea of autonomous cell processes. So things that can happen cell by cell versus system driven. And driving out cortisol, and it's going to affect the whole body. But if I have one cell in a microenvironment that's flipped into that teeter-totter of inflammation and is in glycolysis, and so it's sort of crappy at making energy, then that might be fine. And so maybe metformin would be good because it would increase autophagy and maybe recycle some stuff in the cell or push some apoptosis and maybe get rid of that cell. But if piles and piles of cells all across the body are all in this state, then it's a crappy state. It doesn't have much energy. But if you take that absolutely low energy threshold that lets somebody breathe and survive, like pull some of those dysfunctional cells away, you're pulling a few ATP out at the same time. That's the mental model that I have, and it's I suspect a lot of people aren't old enough to remember it in detail. When Apollo 13 was coming back from the moon, it was bringing the lunar module with it, and the lunar module was this crappy little spaceship thing, but it had an engine that could fire and thrust, and I'm sure actually Tusk probably talked to this a lot better, but and it had some oxygen in it, and they used that thing to get the mothership all the way back to the place where it could drop in the atmosphere and save them. And so I think that by analogy, it may be for people with longstanding or very severe CFS or long COVID that progresses that way. It may be you're tearing off the lunar module in the middle of space instead of made around.
In those cases, when you have sort of that extreme widespread dysfunction, you'd mentioned in breaking down these cells and recycling the pieces, could that also be a portion of it that potentially we're releasing things that are, releasing spike protein, releasing toxins?
Yeah, absolutely. Super question. I think the place where I see it coming up the most, at least in discussions, is with the nicotine protocol, and people routinely get the curcumin reaction, the Hertz reaction, which in all likelihood there, at least by the mechanisms, it's the spike getting released, and well, if that spike gets released, it can cause havoc elsewhere too. So until it can get broken down, and I don't know if there are protocols out there that you can take something ahead of time, and so can they capture the pieces of toxin as they're coming out? I have no idea, but that would be an interesting protocol thing.
Okay, and then our next question is going to come from the panelists, and so I have just brought Dhiren Bhatia. You can ask your question whenever you're ready.
I think you're on mute.
I mean, I can go ahead and just ask the question too, just in case, so that way. If someone has been using high levels of quality curcumin per day, 1,000 milligrams, and hasn't seen any improvements, is that a sign that metformin wouldn't be a good treatment for them?
I don't know the specific answer with 100% certainty, but all of this process is layering pieces that can work on top of each other. And so the metformin would be expected to go in, and it works on the TLR4. And so if the curcumin is not working on it, isn't fighting down the inflammation with it, then you would think that why would something else do it? But metformin also has general activities through AMPK and mTOR1 that there's some antiviral components to it. In the gut, it will create it can move some of the gut biome towards constituents that make short-chain fatty acids. So there could be other things. I can tell you anecdotally, I took metformin and had a level of improvement, and I would say at my worst, I was probably 60 or 70, probably 70% of my sort of cognitive processing speed. So it's totally functional and everything, but I couldn't do what I was used to doing at work in a way. And I think that bumped it up, I don't know, 80, 85, 90, whatever. And then started taking curcumin at a dose of about 40 or 50 milligrams of curcuminoid. It just happened to be the one I was taking, and that helped. And that was from 2020, later in 2022 through the fall of 2023. And in the fall of 2023, I went from about 50 milligrams of curcuminoids to 500 milligrams a day, because I had the experience with somebody who his was more musculoskeletal pain and issues. And I talked to him. He didn't want to take any drugs or anything, and talked to him, and he decided to do the curcumin, and ended up taking 1,000 milligrams of curcuminoids a day, and had really good effect. And at the time, I was personally having some back pain, which I have not had before, and then dove into the literature a little bit further about higher doses of curcuminoids, and found out that it has some effect, and you can see the effect in as little as a week. So I decided to bump my curcuminoid from 50 to 500 in last September, and it made a material difference. And the thing that I noticed in that case was it was some back pain, musculoskeletal pain that quieted down. So I think when you're trying something new, you should, and especially if you're really quite sick or have been sick for a very long time, that going low and slow makes sense, because if it takes 2 weeks to get to the dose you otherwise would have started, but you don't do any harm in that process, that can be better than starting something right away and dropping out of the baseline, or just having a really bad first feeling.
Okay, our next question is from the Q&A, and it's, I am interested in any resources specific to research on inflammation and other diseases, such as scar and alopecia, vasculitis, and specifically GPA.
I am not sure what GPA is. The autoimmune diseases around the head and hair and hair loss are definitely seem to be very related. The rheumatologic diseases seem to be in the same sphere. A number of people with long COVID end up then getting some diagnoses with lupus. And is it true lupus? Is it long COVID that you reverse it and then the lupus is going to go away? Who knows? But they seem to be sort of tumbling in the same sphere. So I don't know if that answered the question. In terms of, interest in looking for resources on it, is there a convenient sort of resource library on inflammatory articles with keeping a remission biome? And if not, then if that's an interest, we could certainly throw some into a place that people could grab. And with the caveat, all this, we're getting thousands of articles a month coming out about inflammatory activities right now. And so that nobody's going to be able to make a definitive library.
All right, and our next question comes from one of our panelists, Caroline, if you are ready to ask your question.
Oh, hi, thank you. Well, I was just wondering what the berberine, or you're pronouncing it differently, so I can't say it the way you said it, but the one that's supposed to be like metformin you were mentioning. What would be like your idea for how much to take and for how long?
Yeah, so all these things have to be in their licensure issues around. It's not a prescription drug, but I've got to be very careful. I'm licensed in New York as a physician, and if I give you advice outside of that, it's medical coaching or something else. And so these are all just general educational discussions, and I think we know that. But a dose that would be very reasonable to think about would be for either one of them, it would be about 500 milligrams a day. And so the dose for metformin for diabetes tends to be 1,000. You can get up as high as 2,000 milligrams a day. But there's a little bit of a U-shaped characteristic to the way metformin works, and the effects of the anti-inflammatory effects can be seen at much lower doses. In fact, there's really quite a well done study that looked at 7 months of looking at pain control and fibromyalgia for people in 7 months, and had a meaningful effect with 250 milligrams. So about 500 milligrams of metformin a day makes sense. Personally, if I go above that, it doesn't work as well for me. I'm 6'2" 200 pounds, and so that's, all these things are dose dependent. But and then in Bear, it's the dosing is actually fairly similar. And just if you're reading, as a side note, it took a while to understand how do you convert mouse doses to people doses, because you see a ton of studies of so many milligrams per kilogram, and you think, holy crap, what the heck is going on here? And it's different in mice and rats, but in mice it's about 11 or 11 and a half as a divisor, but I roughly just think of it as 10. And so if it's 20 milligrams per kilogram in a mouse, and it's 2 milligrams per milligram in a person, and so if it's an 80 kilogram person, it's 80 times 2 is 160. Okay, I want to get something between 100 and 500 or something like that. And it's far from perfect, but it's a rule of thumb that can help to translate when we're reading articles.
All right, and our next question is Nita Jane, if you are ready for your question.
Definitely. Thank you so much for this presentation. It was really comprehensive, and I really like the low-cost approach to treating the condition in general. I think one point about the metformin and the paradoxical results is that I think in some research, it actually ends up inhibiting part of the PPAR gamma pathway via SIRT3, if I'm not mistaken. So I think one of the proposed mechanisms is that it's inhibiting mitochondrial respiration in the gut, and therefore promoting the expansion of proteobacteria. So that could be one thing that is causing paradoxical reactions in some patients. I just wanted to throw that out there. But my question was, I know you mentioned that heparin inhibits the RAGE pathway. Have you seen anything like hyaluronic acid work in this manner as well? And if not, could hyaluronic acid promote benefits via cytoskeletal changes and the immune polarization that would change as a result of having more cytoskeleton integrity? Because I guess I'm just trying to figure out if I'd use liposomal hyaluronic acid, and I'm trying to figure out the mechanism by which that might have exerted any beneficial effects.
Yeah, so I don't know. Is Nick still on? Nick, I don't want to put you on the spot, but you may have extensive expertise in RAGE and hyaluronic acid, and from an agonism perspective. And
okay, no, I've done a bit of research into this before. So I think the size of the actual molecule of hyaluronic acid is really, really important. Like that high molecular weight hyaluronic acid seems to reduce nuclear factor kappa B activation, whereas the low molecular weight seems to increase it. It seems to act as a damp or somewhere in that kind of region, essentially. So it is literally all to do with the weight. I'm assuming that the liposomal form is going to be the high molecular weight version if it is working. Yeah.
Thank you. And one of there are a couple of, if you search, I mean, there's, so I search There's a really good clinical article about rage and I'll see if I can find it. It's that may be helpful just in terms of the pathways that are described. And, I'm not sure if we're going to find it while we're talking here, but these are great questions, and a lot of it is on there.
So the next question comes from one of our panelists. I think she's got a couple of questions there for you, and one requires action on your part. So Ellie, I'll turn it over to you.
Okay. Hi. You just mentioned that you do the telemedicine out of New York. Does that mean your patients have to be in New York, or can you see patients all over the world or all over the United States?
I can talk to people for educational conversations wherever. I can diagnose and treat patients in New York. In these types of this, and I would say the discussion of what we were doing here is more educational. It's a fine line. For a while during COVID, there was an emergency declaration in the U.S. where you're licensed in one state basically for COVID and non-COVID purposes to work across the board. But when the COVID emergency was rescinded, that goes away with it. I went to a longevity conference in New York the other day, and the guys who did Aegis RX were there, and it seemed very decent people. And so that's an easy way to get Metformin, for example. They have providers all over the place. It's not too expensive in the U.S. to get it that way. But in answer to your question, I talk to people all over the world, and the treatment is more just because of the license.
Okay, and is the rage that you're mentioning on your slides, is that the same as is referred to in the test that measures anti-rage peptide antigens that's found high in Alzheimer's? Is that the same?
I don't know. It's the rage pathway, and it is based on your question. It wouldn't surprise me because I think when you hear about amyloid plaques and Alzheimer's, and you hear about amyloid-depleted proteins that are hard to digest in microclots, my understanding is they're both flattened protein structures that are hard to break apart. So I would think that it would be. I personally, this is going way out there in the personal editorial, but I've been scared to death that I got Alzheimer's because it's in my family, and I feel like going down this long COVID rabbit hole into the biochemistry now gives me a lot more confidence that you can do a lot to take care of it. And in fact, one of my favorite statements is sepsis is minutes to hours. And when that happens with the LPS and TLR4, you get a flare across the whole body, and it's a medical emergency. And you've got to quiet it down right away. So the steroids and antibiotics or antivirals or whatever, it really quiets stuff down. I personally think that long COVID is that same process, weeks to months, that is happening because you have this constituent spike heading all over everywhere. And that general aging on Alzheimer's is that process in years to decades. And I think it's all the same underlying process, but I can't prove it.
Okay, and maybe after the questions are through, if you could bring up that Livigor slide again. We didn't have much chance to talk about it, but I think we would appreciate seeing that again.
Sure. Ready?
Okay. That one, and then after a little while, maybe the one that has the $100 a month. I think people were interested in that one as well.
Okay. Well, maybe it has similar information in terms of the approach. Right.
Okay.
Gives people a chance to screenshot it.
Oh, okay.
Thanks,
All
Rochelle.
right. All right, we have one more question in the Q&A, and we might end up, that might be all we've got left. So this question in the Q&A is, can nicotine patches be used? And if so, can't tell what that says. It says Cefudun patches can be cut, so start low and work your way up.
So the idea behind the nicotine patch is that it is ends up being a competitive inhibitor as the spike is invading. I believe it's the spike invasion of cellular binding across nerves and stuff, and that by having nicotine in, it will release the spike, and then the spike can get digested and pulled out of the system. Different people have been you can have different levels of metabolism of nicotine, and then some people are smokers and things have been exposed to it more, and so the level of the nicotine patch, sometimes the lowest level that you can get in a patch is still too much for somebody, and if you get too much nicotine, you tend to feel dizzy and sort of sick to your stomach a little bit, and so the way I believe, and if others know more detail, definitely jump in. I think the way that that folks do it is to excuse me, take the patch and put tape on half of it as an example to lower the dose in half, or fold it over versus cutting it, because of the idea of not wanting to cut it and then all of a sudden make get a big bolus of nicotine all at once. And so I think that's what the question was asking.
Yeah, and the other part of that question, somebody did that, but Cefudun can be cut, so can be used as a quarter patch at the start. So I'm not sure on that one, what kind of patch that is, but that's just me. I don't know. Nicotine patch worked really well for me, so I can't really speak on the Cefudun.
What was, out of curiosity, Rochelle, what was your experience from a timing perspective of it? And if you wouldn't, if it's okay to put you on the spot, whether you were a smoker before or afterwards, so whether you went into it with having known nicotine before or...
Okay, yeah. Before I say that though, we did have somebody ask if you can put the Leviger slide back up.
Oh, okay. I'll back up for that.
While you're doing that, I'll mention my nicotine experience. So to start off with, I didn't really have any exposure to nicotine. I mean, no more than like grew up with some smokers in my family, but I myself was never a nicotine user. So the first patch I started off with was the 7 milligram, and I did the full patch. And I was in like a full PEM crash at the time, and I got that definitely, I was feeling it within 2 to 3 hours. I was really feeling nauseous, orthostatic intolerance from it, which I don't typically have. I actually got to the point that I vomited from the nausea, and then as soon as I rinsed out my mouth, I suddenly went into remission. So yeah, I was just like that. I was yeah, so that was interesting. So I used nicotine patch, just the 7 milligram, then for several months, and was more or less in the prolonged remission. And then I got sicker again in the fall, and nicotine didn't really do much. And so I tried adding more, to bumping up to 14 milligrams, and it still didn't do much. But it turned out I had a UTI. And once the UTI cleared up, then the nicotine patch worked again. And then I triggered another remission event, like a full psychedelic remission event, like as they describe in the full-on remission events and everything. So, well, not quite psychedelic, but like definitely a huge more mental effect too, and cleared up out of that. And it's not been perfect since then, but I have definitely had a significant baseline bump. But I did develop a tolerance to the level of nicotine I was using. So, and I used cutting the backing of the patch, not the patch itself, because, and then using it's like a Band-Aid or something to hold it on when it was like that. So just that was just my experience. Other people have had like significantly felt worse on nicotine. So it's really going to be, there's a lot of variation in it. And especially while I had that UTI, it just made me feel awful. So I couldn't do it then. So it wasn't until I found out I had a UTI when it progressed to a kidney infection. So because otherwise I didn't have what I knew as symptoms. But so there's a lot of variations on who it might work with, and then other people may work better at various times, and other times it may not work anymore. And so there's a lot of flexibility. But I myself didn't have any tolerance to nicotine. I wish I had started off with a half a patch to start off with on that first time, because that was quite miserable. And if I hadn't, I probably would have taken it off if I hadn't had that remission event right away, because I probably would have said this isn't for me, because it was such a strong reaction to the symptoms. So.
And I think I want to just really emphasize your statement about the UTI, and that is, a lot of folks are having these this post-viral inflammatory process, but it absolutely doesn't mean that other things can't be going on in the body at the same time. And I know that we all know that intellectually, but it's really, really easy to say, I'm doing this so it can cause that. And if something new symptom-wise is coming up, if it's possible to somehow metaphorically just step way back and say, is this what I think it is? And how do I know that? And what else could it be? And how big a deal is it if I'm wrong? And so you can look at other possibilities. I think it's really important to not end up down a sort of self-imposed block of just one aspect.
So looks like that's pretty much it, though. In the Q&A, Andrew Boland said he had a very similar response to the nicotine as I did. So with a bump to the baseline and everything too. So it's, again, there's a lot of variations on who it works for, and that we just need to find out more on that. So anyway, are there any other questions? And if not, we may be wrapping things up. Or Ellie, you have a question? You're on mute. Ellie, you're on mute.
I can ask one about heparin. I was one of the ones who took heparin in 1999 when Dave Berg went around, and I did beautifully on it. I took it for 4 years and was able to come off and continue to improve. It took me a few minutes after long COVID, like several months, to realize that the same processes were going on, and I went on it again, and I could feel the circulation return in my fingers and toes. So that's been 2 years now that I've been on it. But when I started fenofibrate, I didn't tolerate the statins, but when I started fenofibrate, to me, it was like heparin on steroids in the way that it opened up my circulation everywhere. Probably from many different effects, because fenofibrate is a COX inhibitor, so it's an NSAID, and it's PPAR alpha involved, and so many things. But I'm just wondering how long I have to stay on them before you address, people can trial the heparin for 4 to 8 weeks. And if they don't feel anything, okay, you probably don't need that or need that right now. But if it does work, is that something you maintain until you get everything working and then try to withdraw? Or do you have any idea?
Heparin is going to, if it's working on the RAGE pathway, that's quieting the inflammation. If you're not taking something that's working on TLR4, you might add that to it and see what happens if you subtract something else off. And all this, right now I'm freestyling in terms of suggestions. It's not, there isn't a singular answer. But it is, and just if you do stop, just be cognizant of what symptoms are. What happened? Maybe it's you switch something to every other day instead of every day, every other week instead of a week, or whatever the dosing is, to just see what happens.
I don't mind giving myself the shots, but do you think it's worth switching to the oral? Do you think the oral thing does something better or different?
I don't know if you're in the US or not.
Yes.
So the senolytics, I know there's some people on the panel here who have gotten it overseas, and I don't know. I know it exists, and it's intriguing to me, but I don't know. I don't have a big clinical experience with it. Any of the other folks, I don't know if there's a ballot and any read into that or not.
Also, we have one more question from Kat, and I think that's our last one.
So ACE inhibitors have come up on a couple of these different protocols. What are the risk factors with people with MCAS who may have high bradykinin?
So the ACE there's a couple things. So ACE inhibitor and ACE receptor blocker. So for example, they're working in 2 different ways. But in the cardiac side, there are there's a bunch of interest in using losartan as a way to block and help with the small vessel disease, which that's the manifestation of this. I don't know the ins and outs of bradykinin and where it fits with the ACE receptor. I think of it as more of the receptors and turning on and off the inflammation, but I just don't know.
Okay, well, thank you so much, Don, for giving this presentation. Really informative, lots of really good information for us to kind of work from here. So again, thank you so much for being here. Thank you to our panelists, and then also thank you to all of our attendees. We really appreciate you being here. And I don't know, Isabel, do you have anything left to say? Okay. She's got some words in the background. So
if people do have questions, I try to answer questions as I can, and I don't always get to all of them, but on Twitter is Dr. Care, or through Nicotine and I think the more discussions there are, and the more we're all sharing this information, the faster it's going to take root to make a difference.
all right, we'll make sure we put your Twitter handle too in the follow-up email to everybody. Thank you for attending. So that way they'll know exactly where it is. And we'll also put that on the YouTube link when we have that posted, so that way people can access you nice and easily. But again, thank you so much for joining us today, and we're going to end that here. All right, have a good day, everybody, wherever part of the world you're at.